So today we will be talking about a social model of support for psychosis. Particularly, we will be talking about the peer support approach, and we'll be talking about the differences between the medical model of psychosis and the social model of psychosis. And the reason why this is so significant is when we talk about the role of people with life experience and supporting individuals who experience psychosis, there are some important considerations from a lived experience perspective that are so important. Here you can see some photos of our community gathering, having discussions, coming together. A little bit of history about Kiva Centers as an organization. I am the chief operating officer of the Kiva Centers. In our early history, we emerged from the civil rights movement, from a movement called the Consumer Survivor Ex-Patient Movement. And the Consumer Survivor Ex-Patient movement emerged within early deinstitutionalization and the trend of deinstitutionalization. The importance of it was really that people in the community did not have enough services. We were looking at a lot of difficult and traumatic experiences that people, particularly people with disabilities, were having in these institutions. And a group called Empower, which was originally the Empowerment Sponsoring Committee, a member-run organization who identified as people as mental health consumers, were really taking the lead in talking about access to mental health services. This eventually led to the creation of many peer-run communities that we know today in Massachusetts, such as the recovery learning communities coming together, learning about recovery. And I think something that was so important was that for a period of time, people would say that people who experienced psychosis, people who had a lot of these emotionally distressing experiences couldn't recover. That they would need these supports for the rest of their lives, and that we wouldn't be able to be self-determined in the ways that we see today. Clearly, that narrative wasn't true, and a lot of that narrative that we've seen has emerged from stigma and discrimination towards individuals with mental health diagnoses. Here you can see some pictures of demonstrations over the years that we've attended, really taking a stance against that stigma and discrimination. I think a rights-based approach is central to mental health, and it's important to acknowledge that deinstitutionalization, as we know it, never really fully happened. We still see institutions present today, even though we also see a robust expansion of community behavioral health simultaneously. I think it's an important consideration when we talk about individuals with mental health conditions and life experiences, that often when we think about ableism and how disability is impacted, particularly there is this perception of inability, disposability, but when you have a mental health diagnosis, people perceive you as dangerous. And we're seeing this rising more and more today. So it's so important when we talk about peer support organizations, life experience and lived experience being at the forefront in creation and development of policy, research, and services, that we've come a long way over these years and that we should continue to tread forward. So a little bit about my own life experience. I am an Indigenous mixed race person. My family's from the Dominican Republic and Puerto Rico. You can see a photo of me there with my great-grandmother, Victorina. She was 97 at the time. And as a young adult, I ended up experiencing psychosis in my teenage years and my preteen years. And really, initially, when I was having these experiences, I found that in a lot of the support and young adult spaces that I couldn't really talk about these experiences. Not enough people were really talking about traumatic experiences or a lot of the things that I was witnessing and struggling with at that time. So I grew up in a place called Plumley Village in Worcester, and at the time there was a lot of gun violence, gang violence, and a lot of things in my surrounding neighborhood. So in public health, we often talk about a built environment, right? And how those environments can impact someone's overall health. when we talk about social conditions and environment and a lot of those pieces. So my environment wasn't very good. It led to a lot of the experiences that I had later in life. I spent about 4.5 years in and out of psychiatric mental health inpatient facilities. And it wasn't until about years later that I started to find the recovery learning communities, mental health drop-in centers that were actually peer run and be in a lot of those spaces. I actually initially came to the Central Mass Recovery Learning Community, today known as the Kiva Centers, as a young adult looking for a lot of these supports. And today I am the Chief Operating Officer. A role that brings me great joy. Thank you. Thank you. Kiva, for a lot of you who don't know the word, means to go deep within yourself and come out healing yourself. It is a Hopi indigenous term. Our executive director is native of New Mexico, where this term emerges from, of the Hopi and Zuni, specifically claimed by the San Felipe tribe. So for me, as a Taino indigenous person, these statements really resonated. And then in the middle, you can see that is me at the United Nations in front of a statue of Nelson Mandela. This was during the Economic and Social Youth Forum. We were talking about the impact of climate change on mental health, the issues of AI and digital phenotyping as it relates to mental health, innovation outpacing regulation when we talk about AI and mental health. So there were a lot of different pieces. And from the perspective of someone who was a consumer, you will, of these services, it was so essential to continue to talk about, we need more people with life experience leading these conversations and talking about how policies and innovations in tech or within our federal or state governments impact us. And then the photo furthest is a Justice for Jordan Neely rally. Jordan Neely was a Black young man who was murdered in a subway train. Someone who was autistic and experiencing mental and emotional distress. He was wrongfully murdered, and there were a lot of protests and demonstrations demanding justice for Jordan Neely. So as you can see, these are many different pieces and snippets of my life's work and where I come from. And the reason why I share this is when we talk about peer support and life experience for individuals who experience psychosis, often the narrative of mental health rights is needed at the center of that. How we are perceived, how we are understood. At Kiva Centers, we do a lot of work on Mass and Cass in Boston, which is a mile stretch of road that has often been called Methadone Mile. And we've really been working to change that narrative to Miracle Mile. Change the name, change the approach. People were evicted from their tents. This is a tent encampment. People are actively using substances there. And often the area is policed. A lot of folks who struggle with psychosis, who are in this area, are often treated in this way. So often this advocacy is at the center of our work when we talk about rights-based work. A lot of you might know this, but I'm going to talk about the origins of the word psychosis. Okay. We're just having an issue with Zoom participants screen sharing, seeing our slides. So it looks right. So screen sharing. Let's see. All right. Stop and start. Excellent, thank you so much. So when we talk about the word psychosis, it originates from the Greek root for psych or psyche, meaning the soul, mind, body, and spirit, or invisible animating entity which occupies the physical body. Um, and then osis, meaning abnormal state, disease, or condition. So when we look at really the roots of the term psychosis and we approach it socially, um, thinking of the condition of the mind, body, and spirit in a lot of ways, I think resonates deeply with a lot of folks who experience psychosis. I think the reason why we're talking about social experiences as it relates to psychosis is for a variety of reasons. We're going to start with the medical model. So the medical model sees psychosis as primarily a medical condition with a biological basis. It often attributes psychotic experiences to factors such as brain chemistry, genetics, and neurobiological abnormalities. This model tends to focus on symptom management through medication and professional intervention. And I think when we talk about professional intervention as it relates to psychosis and a lot of those supports, it's important to have additional considerations. Often when we talk about it in international spaces at the United Nations, we talk about these experiences as biopsychosocial. And I think in research, we tend to talk about them as biopsychosocial. So when we talk about peer support, though, we focus more on the social elements because often that context can be missing in the research and in the services that we see today. And that really brings me to our next piece, which is the psychosocial and mental health disabilities and the social model of disability. How many of you are familiar with the social model of disability? So we have a few hands up here, and I'm sure there's some folks online who are familiar with the social model of disability. But the social model of disability really speaks to this idea that there's nothing wrong with someone's body or mind as they are, but rather society and spaces that people are inside of need to be more accessible to that person, right? Do we ever think of these considerations as they relate to psychosis? How classrooms are accessible, how behavioral health centers are accessible. Maybe for someone who's hearing voices, seeing things, or having a hard time, what does the sensory outlook of that room and that space look like? And the people supporting them in that space, what is the cultural context and understanding of what that person is going through? There was a medical facility in California that was supporting 200 Cambodian patients. And out of the 200 Cambodian patients, 180 of which were diagnosed with some type of psychotic disorder. There's a whole NPR piece about this, and I highly recommend folks check it out. But after a couple of years of these assessments and seeing these trends, a couple of doctors had come to the facility, one psychologist being Cambodian himself. And after looking at these notes and these assessments, particularly realizing, wow, 180 individuals out of these 200 patients having psychotic disorders, that's abnormal. So after doing a reassessment and a series of interviews, they ended up realizing that most of these patients were survivors of the Cambodian genocide. And that a lot of the visions they were seeing were shadowy figures sitting on their stomachs and causing a state of sleep paralysis, or being related to a state of sleep paralysis. And it enormously spoke to how cultural and personal life experience is significant for diagnostic and clinical outcomes. And there are several examples like this in terms of culture that I will get into more. But kind of as we go through here, considering psychosocial and mental health disability from a social model of disability perspective is a good start. So now getting into the social model of psychosis. The social model of psychosis views psychosis as a complex interplay of social, cultural, and environmental factors. It emphasizes that experiences of psychosis are not solely the result of internal biological factors, but are influenced by social determinants such as trauma, discrimination, poverty, and social isolation. As we've seen recently, Vivek Murthy, the U.S. Surgeon General, recently released a report on social isolation and the increase in social isolation causing mental and emotional distress. And when we consider experiences of psychosis and we see what is happening, on a policy level, in terms of individuals experiencing psychosis for the first time, we're seeing a greater need to have the conversation earlier on in people's lives, talking about psychosis, not as singularly this abnormal experience that we fear, but rather leaning into this is more common than we think. This happens in more communities. It happens in rural communities and urban communities. And it happens for a variety of different factors. And seeking to understand that, I think, is one of the most pivotal and important pieces when we talk about mental health and disability rights today. I think often there's this perception that psychosis is a moral failing. And today I want to talk about this idea that psychosis is not a moral failing. We've just yet to understand it. Particularly when we talk about perceptions and understandings of psychosis, we see this portrayal in the public, again, of people being dangerous. We see a lot of Black and brown young adults in police-involved situations as a result of this very perception of psychosis being some kind of moral failing. We see that at the intersection of racism and other forms of systemic violence. And I think at the root of it, I also see that although these things are pervasive and harmful, I also see opportunity. The opportunity within that to really continue on a research and policy and community level to foster leadership of those most impacted in several communities, and continuing to talk together about how our practices can be more trauma-informed and considerate of social outcomes. One example historically that we've seen in terms of psychosis at the intersection of race and racism is actually this piece on the protest psychosis, how schizophrenia became a Black disease. This is a great book. I would recommend it. But The Protest Psychosis is a book by psychiatrist and historian Jonathan Metzl. In the book, Metzl explores the historical and social context of the diagnosis of schizophrenia in Black men during the civil rights era. He argues that the diagnosis of schizophrenia was sometimes used to pathologize and stigmatize political activism and dissent among Black Americans. Metzl's work sheds light on the complex interplay of race, politics, and mental health, revealing how societal norms and biases can influence psychiatric diagnoses and treatment. So I think something that's so significant here, and we've seen some of this research over the years. I believe federally it kind of it varies between 4 or 5 times, but Black and brown and Indigenous people of color are 4 to 5 times more likely to be diagnosed with schizophrenia, according to the National Institute of Health. And I think when we see that trend, we have to wonder when can we see the influence of systemic racism and how it impacts us today. how children and young adults are perceived, how they are seen and understood because of their experiences of psychosis, and how that intersects, particularly with how they are understood in society, their social identity, their social standing, where they come from, what communities they belong to. It is disproportionate, and it is an important consideration. But continuing on a more hopeful note, I want to talk about peer support as a social approach to psychosis. Peer support is a valuable example of approaching psychosis from a social perspective because it emphasizes the role of social connections and shared experiences in helping people who experience psychosis. Additionally, peer support approaches and certified peer specialists are trained to honor autonomy and self-determination first, which promotes peer support as a non-carceral approach to psychosis. So when I say non-carceral, what I mean is non-punitive. Often there's a punitive nature with this consideration of psychosis as a moral failing, which is often a consideration of if you behave better, if you do this better, if you show up in these ways better. Often when people are in an inpatient facility, we often hear this piece of fake it till you make it, right? And where some of those ideas emerge from really are continue this good behavior so you can get through your time here. And I think that that's an important consideration when we think about how mental health is stigmatized today. I think what's so important about certified peer specialists being integrated in medical care and primary medical care is the piece of honoring self-determination first, which is our first code of ethic, and not condoning or abiding by any form of discrimination. Certified peer specialists are change agents who work within systems and social settings. I myself, as a certified peer specialist and as a certified peer specialist trainer, have been doing this work for years. And I think we've seen, even though peer support was understood and made into an evidence-based practice by the Centers of Medicaid Services in 2007, we still see the prevalence of peer support emerging today. I mean, if I were to look 5 years ago at the amount of certified peer specialists we had in the Commonwealth of Massachusetts versus today, that number has significantly increased. And I think a part of that is the social and health outcomes. I think when we consider context and life experience at the center of how we understand and do a lot of this work, we end up having those better outcomes. And I think the reason why I talk about mental health and disability rights at the intersection of each other is particularly when we talk about disability, one of the approaches has always been nothing about us without us. This statement emerged from actually South Africa in the early disability rights movement in the 60s and 70s. And that idea of nothing about us without us is to move away from the creation, the inception, and the design of policies and services without people with life experience. And I think often we talk about people being involved versus really helping take a lead in that process. And when we look at life experience, so many of us have it. And maybe many of us aren't in a position to disclose that life experience. But in some way, your life experience does, inform your professional role in the world. And I think it's important for us to consider that more. I've met a lot of individuals with life experience who have gone into research, who have gone into law, who have gone into many different professions. And I think the more that we foster life experience as it relates to mental health, and the more that we have these conversations around psychosis, not as this abnormal and scary experience, but as something that so many people in our communities experience and are impacted by in their day-to-day lives, the more that we seek to understand it, the more we can move forward as a society that we don't see this reinforced violence on these communities. And the more that I think professionals will be comfortable and able to talk about and hopefully eventually be able to disclose without fear that they've struggled. I mean, I can't tell you how many people who are currently working towards their undergraduate degrees or their graduate degrees are struggling with mental and emotional distress. How many students I've talked to who are like, can we have a peer-run respite on our campuses? Can we how can we start peer support groups in different spaces nearby? Because there's such a need. And when we look at communities geographically, especially rural communities, we see a rising need for peer-run drop-in centers and access centers in rural communities, where people are often isolated, and we see that rise in isolation. So the peer support approach recognizes that experiences of psychosis have a wide range. I think spiritual experiences is one that's really important, and I'll actually be talking about that a bit in the next example. Trauma and the impact of trauma as something that is widespread, that can be both directly and indirectly felt, I think is significant as well. Grief and how grief impacts our communities. And I don't mean just grief in terms of loss and people in our lives passing away, but I do mean grief as in grieving the state of the world, grieving social struggle, grieving how we continue to move in a society through our emotional distress. There's one great example of the hedonic treadmill, where we kind of continue to go and go and go and go and struggle through life and conflate our value with what we can produce and do, other than understanding that our value is inherent. You don't need to do something to be valuable in society, to be worthy. Unfortunately, often when folks struggle with that personal value, there's not enough people to actually meet with them, support them, and say, hey, even though you're struggling and going through it right now, I know what that's like to a certain extent. You're not alone. There are so many people here with you. You don't have to feel odd or abnormal in this experience. And in life, you can simply exist and be strange, and it's okay. I think that that's so important to grief. I think when we talk about the role of peer support, it's not necessarily trying to move someone in one direction or another in their journey, in their recovery, in their healing, but instead to be present, to be a witness in that moment of struggle, and to be someone who is both relatable and willing to follow them along that journey. I think a few years ago, we saw this article on holding space in moments of grief. And holding space is basically the idea of when there's a grief that is so incomprehensible that someone is struggling with, instead of saying something to tell them to particularly take this direction or this direction in processing their grief, instead of moving through the 5 stages of grief, which for me, I think there's more than 5 stages. I don't think grief is linear. Grief looks different for everyone. That instead, you are present with the person in silence. You ask them if they may need a glass of water. You take a moment and you carefully listen. Silence, in a lot of ways, people say silence is deafening because a lot can be said in silence. Sometimes you can see someone who is currently grieving and sitting in a space and struggling in that moment, and you see that they're not saying anything. And a lot of that hesitation can be informed by their life experience. Well, the last time I spoke out about this, my family thought I was crazy. Well, the last time I spoke out about this, I lost that job. Well, the last time I spoke out about this, I had to go see the school counselor and I had to take leave. And I was so behind on all my classes. Personal context really informs why someone's. And then when we talk about psychosis considerations for chronic illness and disability, we're seeing a really, particularly for folks with chronic illnesses and first experiences of psychosis, it's so important to consider how pain, malnutrition, so many other factors really lead to those first experiences of psychosis. Earlier during the poster presentations, I was reviewing a poster presentation where we talked about diet as it relates to psychosis. And it reminded me of someone in our Kiva community who actually switched to a paleo diet and found that they were no longer experiencing the same distressing voices and visions that they had been for years, just from a change in diet. Sometimes it's a change in diet, sometimes it's a change in environment, sometimes it's a change in social setting. And I think in order to understand that, we have to consider a lot of these contexts. Substance use and recovery as an interplay when we talk about psychosis as well is so significant. All right. So I'm going to take us kind of out of the Western medical model for a moment. I'm going to talk about the Dagara tribe in South Africa. So the Dagara tribe in South Africa understands mental health and psychosis as gifts that are not yet harnessed from youth in their communities. Often elders in the community support young adults who are experiencing those experiences for the first time and how they can navigate it and how they can work together collectively. Particularly, mental health is seen as a reflection of the individual's relationship with their community, their ancestors, and the spirit world. Rather than pathologizing psychosis, the Dagara people view it as a potential gateway to spiritual growth and transformation. When someone in the tribe exhibits signs of psychosis or mental distress, the community comes together to support and guide the individual. The shaman, with their deep understanding of the spirit world and the psyche, plays a vital role in facilitating this process. I think in the Western context, and the way in which we've understood peer support is playing this role for a lot of people. Maybe not always in the spiritual sense as it relates here, but particularly someone who has experienced it before, walking with them, being a witness to the struggle or to the opportunities and the realizations that may emerge from early experiences of psychosis. I think something that is so critical as well is we see new approaches developing outside of the United States and Europe and in different parts outside of the Western medical model, and utilizing elements of the Western medical model to actually implement new processes. So in Zimbabwe and Ghana, we see the initiative of Friendship Bench. I don't know if any of you are familiar with Friendship Bench. The Friendship Bench is a model where grandmothers and elders in a community are trained in DBT and CBT, and they sit at park benches to support people who are struggling with suicide and emotional distress. A lot of them are retired or are finding other ways to give back to their community. Older populations and elderly populations are often viewed as less valuable in our society. So it's a good opportunity for them to be able to give back. And simultaneously, it's a great opportunity for folks who are struggling in those moments to receive support from an elder in their community, especially when that's built into the social structure. Zimbabwe has seen a 42% decrease in rates of suicide since starting Friendship Bench. So I think it's important that when we view peer support, I like to think of peer support as a combination of what we understand in Western medicine and beyond Western medicine. Social medicine, if you will. People coming together, sharing stories, sharing life experience for better outcomes. All right, so peer support for psychosis, altered states, and other sensory encounters. At Kiva Centers, we have a Living with Loss peer support group where we talk about grief and struggles of grief across many different contexts. A lot of people within the Living with Loss peer support group discuss struggling with grief, but also hearing the voice of a loved one that has passed away, whether recently or years before. And a lot of folks come into that space being able to describe the voice of a grieving, to describe the voice of a loved one who has passed away, and being able to grieve that and walk through that journey without someone initially assessing or trying to understand what's going on, but instead, again, be present with them. Something similar in our Hearing Voices and Alternate Realities peer support group. We see people who are discussing experiences of their current reality as it relates to hearing voices, seeing visions, or having other sensory encounters, the things that we often call psychosis. And the reason why we say hearing voices, seeing visions, and all of these things is we're trying to describe the social experience versus necessarily saying if it is psychosis or something else. Sometimes people determine that the voice they are hearing of a loved one is there for a period of time for them to process some grief, and then that voice goes away. We've seen other occasions where someone feels the voice that has come to them is the voice of God or a spiritual entity. And again, that flexibility to not necessarily define those experiences in that moment and be present has been really, really crucial in our community. In our chronic illness peer support group, we've seen a lot of folks who are struggling with different immunocompromised conditions, particularly lupus, endometriosis, and a few others, where people are hearing voices and struggling for the first time. And a lot of folks go to the group and they're like, does anyone else who experiences chronic pain start to hear these voices from, after being awake for several nights, after feeling this way? And a lot of folks in the group share those experiences and say, yeah, me too. You're not alone in this. In our Coping with Anger peer support group, we talk about the struggle for a lot of folks at the intersection of anger and sometimes hearing voices. We have people who describe hearing command voices, a voice that tells them to do something that feels really, really related to the rage that they are feeling in that moment. And in the Coping with Anger group, we're able to discuss that, unpack that, take a moment and process it. And again, without necessarily pathologizing it, taking a moment to talk about the social impact of these experiences. So now I'm going to talk about our peer-run respites. This image that you see is from the Safety and Justice Challenge. We did the Safety and Justice Challenge in Pennsylvania, and the whole idea of the Safety and Justice Challenge was to talk about new approaches to how we understand policing for individuals who may be struggling with mental and emotional distress, whether that be law enforcement, social workers, mental health professionals, or services in the communities. Our peer-run respites offer rest and reflection for all people experiencing emotional distress. We support people through what is called crisis to find healing. Kiva Centers peer-run respites are a statewide Massachusetts-based initiative. Specifically, we have 3 peer-run respites. One called Karaya peer-run respite. Karaya is actually the Taino word for moon, and the moon is known as symbolic of rest and self-reflection. So I myself am a Taino person. The indigenous people of the Dominican Republic and Puerto Rico are the Taino, and taking these concepts and putting them at the forefront and the center in our community have been so essential to again centering the social experience and understanding the community. Our Kiva Centers community was primarily a Puerto Rican and Dominican community back in 2007 to 2014. We still have so many Puerto Rican and Dominican community members, although I would say more today. We see more community members coming in from Ghana, coming in from Haiti, coming in from other countries. And it was important for us to name our first house Karaya to really represent that community. We have another peer-run respite in a more rural community named Juniper, and it's a 4-bedroom house in Bellingham, Massachusetts, which is a more rural area. And the reason why we opened Juniper in Bellingham, Massachusetts was because we hadn't seen many services in that area. So we thought it would be a great means of offering services to people in a rural community that could use an introduction to peer support in moments of crisis and deep emotional distress. Then we have our new La Paz peer-run respite in Dudley, Massachusetts. This La Paz is the Spanish word for the peace. And the reason why it's named La Paz is because our Southbridge community thought, oh, well, what about a peaceful environment? And a lot of folks in our Southbridge community are older adults who are Puerto Rican, Dominican, and Cuban. And we thought it appropriate to have plenty of staff who spoke the language, understood the cultural contexts, and to have a peer-run respite space in Dudley, Massachusetts as kind of an in-between point for South County, in the South County area. But as you can see in the image here, you see some folks talking about their experiences. Particularly, you see folks talking about their struggles, maybe as it relates to their medication, how they're adjusting to their medication, and talking to each other and saying like, yeah, I've had a similar experience, sharing coffee, being in these spaces together. Particularly at the peer-run respites, we find a lot of moments where folks are struggling with finding housing and housing supports. We're seeing a rise in immigrants and migrants coming to Massachusetts, looking for opportunity and hopefully safety from a lot of the situations they are coming from. And we are seeing this need to understand mental health differently. I think particularly for myself, as a first generation American from my family, my mother immigrated to the United States before I was born. She became a citizen when I was 4 years old. And a lot of the messages that she told me when I was growing up were basically, you have to work hard. And you can't always take a moment to process what you're feeling. You have to keep going. You have to continue to persevere. So for me, in a lot of respects, I feel like I was inheriting dreams from my family constantly. And I think something that is so important when we talk about the cultural context of psychosis and experiences of mental health is that often that context is missed. The fact that so many of us are expected to attempt to persevere in a society and continue with so many social barriers. And I see we're at 11:56, so I'm going to get through here. Here are some pictures of our Karaya Peer Run Respite. As you can see, the rooms have warm colors on the walls. You can see in one of our living room spaces, we have an acoustic guitar resting against a couch. We have games. And as you can see in our kitchen, we have turquoise walls and a nice table where folks can gather. Actually, where that clock is, we put up kind of like a UV blackboard cafe style board for folks to be able to write about the meals they're cooking that day, or when folks are coming in to be more trauma informed, or messages that folks want to share with each other. I think when we talk about social environments and folks who experience psychosis and emotional distress, to have warm environments that are inviting in this way, staffed by people with life experience, and to be able to process what you're going through for 5 to 7 days is such a powerful experience for so many. And now I just wanted to briefly go over all that Kiva Centers offers, a lot of our key projects. We train certified peer specialists in Massachusetts. We do 7 trainings a year. So usually if you have a certified peer specialist who is working on your team, supporting you, they've likely been trained by us. We offer technical assistance throughout the state of Massachusetts, but also throughout the country. Earlier, someone was talking about peer support and Medicaid and Medicare billing. We will be going to a congressional hearing next week and speaking about Medicaid and Medicare billing as it pertains to peer supporters. Specifically looking at different pieces of the process. Can peer supporters be supervised by peer supporters and not only licensed clinical social workers? Can there be a process in terms of a unique diagnostic code that is non-specific? So the certified peer specialist doesn't necessarily have to be in a position where they have to enter this person's diagnosis, which is compromising to the role and the ethics of certified peer specialists. And we're also talking about approaches to documentation, really being led by those we support. Again, being led by those who are most impacted. We have a peer support line that people can call 8 p.m. to midnight, Monday through Friday. And we offer a variety of peer support trainings. We have a workforce coalition. We offer peer bridging for a lot of folks who are inside inpatient facilities coming back out to the community. And then we have our Kiva recovery learning communities, which are in 98 cities and towns in Massachusetts. And we have 2 centers, one in Worcester and one in Southbridge. But the groups that we offer are in a lot of the time in coffee shops and libraries and other social settings out in the community for folks who are looking for those supports in the community. So I wanted to take time for questions, and I wanted to say thank you for taking the time. But we started about, I think, 10 minutes late. Would we say 10 minutes or 5 minutes of questions? Excellent. 9 minutes, thank you. All right, we'll start in this room. Do folks have any questions, comments, thoughts? Yes.
I feel like I guess the sort of implementation incentive and years going forward. I think like the meetings that we are sort of like at the first extent of policy. And very much I really love it. And we can do it. But something I was thinking about is like at an organizational level, from like hospital to hospital. What are some things that I know that in the hospital getting in the whole tier department, so here's start running here's going to supervise each other. I guess what do you think at an institutional level can be done with the hospitals?
I think it's a great question, talking about on the institutional level, what can be done in a lot of these spaces. I think a lot of supervisors and administrators and folks who work in the human resources departments could benefit from understanding the peer support role more, particularly the role of certified peer specialists, peer recovery coaches, and young adult peer mentors and older adult peer specialists. I think that is crucial, particularly when we're looking at more and more of an integrated healthcare system, offering these varieties of life experience and peer support professions overall. So I think education is at the center of that. We at Kiva Centers do some of that education. We actually do some of that education with Carillon through the Massachusetts Behavioral Health Partnership, where we train a lot of staff at different provider agencies about certified peer specialists, what the role looks like, what the values look like, how the role can be implemented in your organization, how it can work well with other professionals on the integrated team, what is needed to see that role thrive in those spaces, I think is so important. Because I think what we see often is fast-paced implementation without enough information about how this implementation can be most effective. And I understand the pressure of that. You know, funding streams are coming in, you have to implement all of these things. But those additional trainings, you will see better outcomes in your organizations. There are plenty of peer-run organizations doing a lot of that work. There are young adult access centers. There are recovery learning communities. There are other types of peer-run drop-ins through the substance use recovery community. There's the independent living centers who also offer that physical disability context and cross-disability context. So there's a lot of valuable education in the community. Yes.
We have a question from online asking, could you talk a little bit about what type of peer support particularly resonates with young adults?
Absolutely. So the question was, what type of peer support resonates most for young adults? And so there are several trainings. There's the gift training and the core elements of young adult peer mentoring, and the role of the young adult peer mentor. I think what is most valuable, particularly for young adults in different settings, is the consideration of the social struggle for young adults. Young adults are a moving social class. Your life is different when you are 16 years old versus when you are an adult at the age of 18. There are developmental considerations too when you're a young adult. Support in terms of vocational education, supports in terms of how to navigate the educational system, maybe anticipate the potential emotional distress when you do go to college, or maybe if you don't have access to college, continuing that education in some type of way and receiving those supports. I think the most effective supports that we see are ones that are culturally responsive, ones that are considerate of a lot of these factors, and most ideally operated by young adults who have recently experienced that. And I know that that can be a challenge when you're looking at administrators for like a young adult peer-run organization. But I can say throughout the years of what I've done in terms of young adult peer support and what I've seen, that when you have someone who has benefited from young adult peer support in the community, taking the lead of what that looks like, I've particularly seen communities who have just really flourished in terms of their understanding and the supports that they've received. So yeah, I think considering all of those factors is important. I think I saw another hand. Yes.
Thank you so much for your work that you're doing in the community. This is the first time I've heard about the peer-run Vesper, and I'm super curious about it because state access to housing for folks who are struggling is so hard to find. So I'm super curious about how folks get in, what the growing feelings of developing these services, trying to expand in order to provide more housing. I'm curious about how that can go compared to other
Of course. So the question was implementation, growing pains, I think it relates to peer-run respites and a lot of other pieces. So I think it's really important that when we talk about our peer-run respites, we opened our first one, Karaya, in 2021. So it's been 2 years, and we have 3 peer-run respites. There have been a lot of things that we've learned along the way. I think in terms of considerations, and it's again, I would say it's for both peer-run environments and non-peer-run environments. That environment matters first and foremost. So sometimes I think something that's so important is that the absence of negative messages is more important than the presence of positive messages. That's not to say that the presence of positive messages isn't important, but if you have a sign that says you're a flight risk, and then you have another sign that says, have a nice day, I didn't hear have a nice day, you know? So those are important considerations, you know, and from a policy perspective, it is important to have some of those messages up in terms of implementation of that environment and what that environment can look like, and mitigating liability and working through circumstances of liability. But I think improving spaces that in some way are led by the people who are most impacted by those services, talking about what they want that environment to look like is an important piece. Now, I think that's a challenge because trying to interpret all of that can be a challenge. Community consensus in a lot of regards can be a challenge. I think along the way, some of the things that we've learned and some of the things that have been most effective, particularly have been implementing more practice kind of across disability. So for example, we had one guest who stayed with us who was deaf, right? And they were like, I need a bed shaker to help me wake up in the morning. You know, there were other folks on our team who were like, wow, I didn't even think about that cultural context. So we got a bed shaker and we installed it, and we were able to support them in how to use it. I think other considerations too are cultural considerations, which we talked about earlier. Language barriers, increasing language capacity is huge kind of across services right now. And I think a big part of that is talking about peer-run communities for different types of communities. So it would be great to see like a migrant-run, peer-run respite sometime in the future. It would be great to see peer-run respites run by people who were unhoused for years and years and years and who struggled with housing. I think something that's been so significant at our peer-run respites is that we have a lot of people on our team who have struggled with housing, who know the resources firsthand. Then we have other people on our team who are trained as both certified peer specialists and housing specialists. And that's been critical because we're a step in their journey, you know. They're with us for 5 to 7 days, right? But if they are given the resources and the life experience is shared in dialogue of like, these were the challenges and the barriers I faced, they might look different for you, but we can support you along the way. And then there's continuing support in the community. We see something that is very effective for that person's wellness and well-being overall. And when people stay at our peer on respite, it's not the end of the resources through Kiva. They can come to our recovery learning community. They can come to one of our peer on drop-ins and continue to get that support. We can work with them in getting DMH services or other services. Yeah, I don't know if that fully answered your question, but thank you. Okay, one more. And are we at the time mark? We're at the time. Okay, so then can we take this last question? All right, thank you.
Is there a way to get them to approve on respite right now? Is there like a certain time that they have to do?
So when someone applies to a recommendation form to stay at one of our peer run respites, all you have to do is go to our website under peer run respite. There's recommendation forms for both mobile and on-site peer run respite services. And after that, we contact them within 24 to 48 hours. And then from there, it depends on how many individuals in that area are waiting to get into that peer run respite. Sometimes we have an upwards of 18 people, like that's the most I've seen at a time for people who are waiting to come in. But if the person is waiting, we can also offer mobile peer run respite, where we come to them in the community and we support them for 1 hour, 30 minutes, maybe up. The absolute maximum is 4 hours. But yeah, so we can offer that till they come. Awesome. Thank you all so much.